Dr. Ritesh Roy is an Associate Clinical Director and HOD at Care Hospitals in Bhubaneswar in Odisha. He is the innovator of many different blocks and an executive committee member of AORA India and has received the Lifetime Achievement Award in 2019. His special interests include USG guided RA and difficult airway management.
Thank you. Now coming to the PNS guided ilioinguinal iliohypogastric nerve block. Coming to the functional anatomy. The ilioinguinal iliohypogastric nerve is a branch of lumbar plexus. After its origin, they emerge from under the psoas major muscle. They run anterior to the QL muscle. They initially run deep to the transverse abdominis muscle, posterior and cranial to the anterior superior iliac spine. The two nerves enter the transverse abdominis plane. This is the transverse abdominis plane where they lie between the transverse abdominis muscle and the internal oblique muscle. Medially and caudal to the anterior superior iliac spine, the two nerves pierce the internal oblique, the external oblique, and they then divide to provide the cutaneous innervations. The iliohypogastric nerve gives a medial branch, that is a sensory innervation to the abdominal wall above symphysis, and a lateral branch which provides the sensory innervation to the anterior buttock. The ilioinguinal nerve gives a sensory innervation to the superior medial aspect of the thigh as well as the anterior region of the scrotum in male or mons pubis and labia majora in female, and motor innervation to the internal oblique and transverse abdominis muscle. This motor innervation to the internal oblique and transverse abdominis muscle is the main concept behind the PNS guided ilioinguinal iliohypogastric nerve block. And there is only one publication. This is the first innovation by our own Surajit Giri, a novel approach to the ilioinguinal and iliohypogastric nerve block using PNS for hernia surgery in around 100 patients. And this is the only publication till now. So I hope after seeing this lecture, there might be more publications coming in future. This is the equipments which we use. I am not going into detail the PNS equipments. These are the PNS settings. What is the acceptable motor response? At 0.4 to 0.5 milliampere, we want to see the twitches in the lower abdominal wall and inguinal region, that is the T10 to L1 territory. And what is the local volume and concentration, which the initial authors had used around 25 to 30 ml, and the concentration depending upon you want to give a post-op analgesia or a surgical anesthesia. But I have come down to the volumes. I usually use around 15 to 20 ml right now. So what are the landmarks and needle insertion site? This is the anterior superior iliac spine. The patient lies supine, 5 centimeter cephalad and 5 centimeter posterior. This is the point of your needle insertion. Why this point? Why this point the authors had chosen? And this point comes from these two publications. Why this point was chosen by the authors? Because at this point, the ilioinguinal and iliohypogastric nerve lie between the internal oblique and transverse abdominis in more than 90% of cases in the region above and posterior to the anterior superior iliac spine. And the both nerves are usually not divided and are thick. It is around 3 mm and 2 mm in transverse diameter respectively for ilioinguinal and iliohypogastric nerve at this point. So it is possible to stimulate these nerves using a PNS. And third, the distance between the two nerves is less than 1 centimeter at this point. So if we deposit 20 ml of local anesthetic at this point, it will effectively block both the ilioinguinal and iliohypogastric nerve. So that was the reason this was the needle insertion point which was chosen. A 50 mm insulated needle is inserted perpendicular to skin. Feel for the pop, the facial click of the external oblique and internal oblique fossa. After that, that is 2 pops. After that, you switch on your peripheral nerve stimulator at the settings which I have already told, around 1.5 milliampere on a sensi mode if you have got a sensi mode, and start stimulating. So, this is the response you will see. Around 1 milliampere, you start seeing the contraction in the lower abdominal wall and the inguinal region, that is T10 to L1 territory. Start reducing your current. If you are getting this response at around 0.4 milliampere, inject your drug, and your ilioinguinal and iliohypogastric nerve will be blocked. You can reduce your current to 0.2 to prevent intraneural injection, and then again make it 0.4. If the drug is in the right plane, you will have a free flow of local anesthetic. It means the drug has been deposited in a correct TA plane where these two nerves lie. So what are the indications? You can use for inguinal hernia surgery as a sole anesthetic in a concentration of 0.5% in combination with genitofemoral nerve block. You have to combine if you give a genitofemoral nerve block. Or you can use for a post-operative inguinal analgesia for the post-operative inguinal hernia surgery. You can use in cesarean section. I personally give for cesarean section, I give only ilioinguinal, iliohypogastric nerve, whether it's a PNS guided or ultrasound guided. I don't give tap block because it has been reported that in many of the tap blocks, the L1 is paired. You want a L1 dermatome to be blocked for a cesarean section. You can use for post-operative analgesia for any incision on the lower abdominal wall, that is the L1 dermatome. Complication, chances of vascular injury is there because the ascending branch of deep circumflex iliac artery runs along with this nerve. Anybody who is practicing the USG guided ilioinguinal iliohypogastric nerve can appreciate it that this artery is almost besides these two nerves. So take care of it, aspirate and inject. Even if you puncture, don't worry, just put a pressure and it will be fine. Nerve injury is there, so always reduce your current and check your injection pressure. And last, if you are giving a bilateral injection, if you are using for a cesarean section. Thank you very much.